Hello, good morning students. Last class we discussed about classifications of arrhythmia. Among the classification, today we can discuss about sinus node arrhythmias. That's of sinus arrhythmias. I already told under sinus arrhythmias there are about 7 major arrhythmias. They are sinus bradycardia, sinus tachycardia, sinus arrhythmia, sinus arrest, sick sinus syndrome, wandering atrial pacemaker, and SA block. Before going to sinus arrhythmias, you can just recall the normal sinus rhythm. As you all know, the normal rhythm that's originating from the pacemaker, that's of SA node, and it's transmitted to the atria and down to the ventricles. Now, the rate of that's of 60 to 100 beats per minute. Again, they are all regular rhythm. So, regular rhythm, and the QRS complex that's preceded by a P wave, and the PR interval, normal PR interval is 0.12 to 0.2 seconds. That means 3 to 5 small squares. The QRS complex, that's of 0.06 to 0.12 second. That's of 1.5 to 3 small squares. Keep in mind all these points: PR interval, QRS complex, about the normal rate, and about the rhythm. For this normal sinus rhythm, the person is okay and the patient doesn't need any interventions. Now we can move to abnormal sinus rhythms. First we can see the sinus bradycardia. Bradycardia means decreased heart rate. The sinus bradycardia occurs when the sinus node creates impulses at slower than the normal rate. Sinus node discharges at a rate of less than 60 beats per minute. Now, the sinus bradycardia is regular rhythms, having regular rhythm. Also, the sinus bradycardia that's often seen as normal variation in some categories. The one factor is during sleep. If the person is having sinus bradycardia, means we are considering it as a normal rhythm even during the sleep. Again, in case of athletes, for them also we are considering sinus bradycardia as a normal rhythm. Again, in response to vagus maneuver, we are considering sinus bradycardia as a normal rhythm. Now, we can see the characteristics of sinus bradycardia. The ventricular as well as the atrial rate that usually less than 60 in case of an adult. Rate less than 60. Again, the ventricular as well as atrial rhythm, it's so regular. The third point about the P wave. P wave that's of normal, consistent shape, always in front of a QRS. Now about the QRS. Shape and duration, like usually normal, but maybe regularly abnormal. Usually normal, but maybe regularly abnormal. But they are following a regular pattern, even abnormal also. Again about the PR interval, consistent interval between 0.12 to 0.2 seconds. Again, P is to QRS ratio, that's so 1:1. That means all characteristics of sinus bradycardia are same as those of normal sinus rhythm, except for one thing. What is that? Except for rate. That's the characteristics of sinus bradycardia. Now, we can see why this sinus cardia will occur. Which all are the causes? Considering the causes of sinus bradycardia, first comes the lower metabolic needs. Examples during sleep, even during athletic training, in case of hypothermia, in case of hypothyroidism, there is lower metabolic needs. That's a cause for sinus bradycardia. The second reason is vagal stimulation. That also from vomiting, suctioning due to severe pain or due to severe emotions or severe stress. There is vagal stimulation. That's another cause of sinus bradycardia. Then consider some medications, especially calcium channel blockers, amiodarone, beta blockers. These drugs also say cause for sinus bradycardia. Then another cause, that's of increased intracranial pressure. Another one is myocardial infarction, especially of inferior wall myocardial infarction. These all are the causes of sinus bradycardia. Once more I will repeat, lower metabolic needs, vagal stimulation, medications, increased ICP, and in case of inferior wall MI. Now, move to some clinical associations of sinus bradycardia. It occurs in response to carotid sinus massage. Second, in response to hypothermia, again during increased vagal tone and even administration of parasympathomimetic drugs. These all are some clinical associations of sinus bradycardia. Now, some more clinical associations are there, that hypothyroidism, increased ICP, obstructive jaundice, inferior wall MA, that also we discussed as the causes. Now we can see the significance of sinus bradycardia. If there is sinus bradycardia, there is chance of hypotension. That's due to decreased cardiac output. Again, an acute MA may predispose the heart to escape arrhythmias and to have premature beats. That's another significance of this sinus bradycardia. Now we can move to management, the treatment. Usually, the person is asymptomatic. We can just observe the person, monitor the patient, that's enough. But symptomatic means oxygen, we have to administer. Then atropine, that's all 0.5 to 1 milligram given rapidly as an intravenous bolus. This is the medicine of choice for treating the sinus bradycardia, atropine, 0.5 to 1 milligram. The reason is that it blocks the vagal stimulation, thus allowing normal rate to occur. That's the action of this atropine. Again, rarely we are using catecholamines. In case of emergency, have to perform pacing. That also transcutaneous pacing. That's implanted in case of emergency. If hypotensive, dopamine also we can use as a choice. This is all about the treatment. These all are the points related to the treatment of sinus bradycardia. Now move to nursing interventions. Our responsibility is to assess the patient. How to determine the hemodynamic monitoring. How to do the hemodynamic monitoring. Then how to find out the possible causes of this problem, sinus bradycardia. If it is due to stimulation of the vagus nerve, such as bearing down for defecation or due to vomiting, in that situations, we must take steps to prevent further vagal stimulation. If bradycardia is from medications such as beta blocker, we have to withhold that particular medication. If the slow heart rate causes significant hemodynamic changes, that may result in shortness of breath, decreased level of consciousness, angina, hypotension, ST segment changes, premature ventricular complexes. So we should be very careful, and our responsibility is to monitor everything. And if any change, report immediately and start the proper treatment. This is about sinus bradycardia in general. Now we can move to the second type of sinus arrhythmia. That's so opposite of sinus bradycardia. That's sinus tachycardia. Sinus tachycardia, we usually call it as sinus tach, short name. That is characterized by rapid, that means greater than 100 beats per minute. That's the rate of discharge from the SA node. All other starting, the generation of beat is like that, but the remainder of the conduction follows the normal pathway. We can see the sinus tachycardia ECG. ECG criteria involve heart rate, that is greater than or equal to 100 beats per minute to 160 beats per minute. About the rhythm usually that's of regular rhythm. Again, move to P wave, that is upright and normal. One P wave proceeds every QRS. Then PR interval, that's a normal PR interval. QRS width less than or equal to 0.12 seconds. These all are the ECG criteria related to sinus tachycardia. Now we can think about the possible causes, the reason for sinus tachycardia. The causes include, first one is it's a normal response to demand for increased oxygen need. Normal response for demand for an increased oxygen need. Examples: when the person is having stress, or he is having pain, or the person is having some fever, or during dehydration, or during extreme exercise. What is the possibility? The demand will increase, oxygen demand will increase. In response to that, there is possibility of tachycardia. Another cause is like that: excessive use of caffeine, excessive use of alcohol, and nicotine ingestion. The third cause is of hyperthyroidism. The fourth is the use of recreational drugs like cocaine. And the last one, post-MR or early sign of heart failure. As an early sign of heart failure, sinus attack will occur, or post-MI patients we can observe this sinus attack. These all are some causes of sinus tachycardia. Now we may see the clinical associations. That's the same as that of cause. Clinical associations: hypotension, hypolemia, myocardial ischemia, congestive cardiac failure. These all are some clinical associations. Now move to the significance. What's the significance? The significance of sinus tachycardia. The increased myocardial oxygen consumption. That is important. How to consider that point. If the person is having sinus tachycardia, the significance is that there is increased myocardial oxygen consumption. Or in patient with acute MI, if there is persistent tachycardia, you can observe persistent tachycardia means that may increase the infarct size. They are continuously monitoring the cardiac rate, rhythm and ECG of the patient. That time, if there is persistent tachycardia, that indicates that may increase the infarct size. Again, if there is tachycardia, we have to observe for the symptoms of dizziness and hypotension. There is decreased cardiac output. That's why should be thoroughly observe the patient for these symptoms. This is about the clinical significance of sinus tachycardia. Now move to signs and symptoms. You know there is decreased cardiac output. That's why the signs and symptoms including dizziness, shortness of breath, lightheadedness, rapid pulse rate, heart palpitations, chest pain, syncope. These all are some clinical manifestations. Must see the risk chance of sinus tachycardia. The cardiac output may fall due to inadequate ventricular filling time. That's a risk. Decreased cardiac output. Every multi-system effect will be there. Again, myocardial oxygen demand will increase. So there is chance for further ischemia. Can precipitate myocardial ischemia or infarct. These all are some risk factors. Now, treatment. If asymptomatic, only observation is needed. But symptomatic means treat the underlying cause, whether it's dehydration, anxiety, whatever it may be, how to treat the underlying cause. The drugs such as beta blockers, they may can give in order to slow the heart rate. Again, beta-adrenergic blockers to reduce the heart rate, myocardial oxygen consumption. Again, calcium channel blockers. That also helps to reduce the heart rate. Now, nursing management. For that category of patient also, how to assess the patient, find out the etiology, then monitor the patient continuously, give oxygen, monitor the oxygen saturation, monitor the blood pressure, heart rate, start IV fluid. If it's not already established, means how to start the IV fluid. This is about the nursing interventions. Now we can see ACLS protocols too. ACLS protocols. The patient came with this particular sinus tachycardia. Look for the cause of the tachycardia and treat it. Second protocol, fever, give acetaminophen or ibuprofen. Stimulants are there, stop use caffeine, over-the-counter medication, herbs and illicit drugs. Stop use that. Anxiety, give reassurance or anti-anxiety medication. So sepsis, treat for that. Anemia means how to treat hypotension, MI, heart failure, hypoxia, whatever it may be. How to find out the cause and treat it. Then narrow QRS complexes. Consider the vagal maneuvers, adenosine, beta blockers, calcium channel blockers or synchronized cardioversion. If there is wide QRS complexes, consider anti-arrhythmic drugs such as procainamide, amiodarone. This is the sinus tachycardia ACLS protocol. Now, two arrhythmias over. One is sinus bradycardia, another one is sinus tachycardia. Now move to the third type, that's of sinus arrhythmia. Sinus arrhythmia. Sinus arrhythmia, that refers to an irregular or disorganized heart rhythm. Both irregular and disorganized heart rhythm, in which the rate usually increases with inspiration and decreases with expiration. Both rate and rhythm, that there is abnormalities. Non-respiratory causes include heart disease and valvular disease, but these are rarely seen. Anyway, irregular, that is a disorganized heart rhythm, increases with inspiration and decreases with the expiration. Now we can see the ECG criteria of sinus arrhythmia. Ventricular and atrial rate, that is of 60 to 100 in adults. 60 to 100 ventricular and atrial rate. Ventricular and atrial rhythm, irregular QRS complex, irregular QRS shape and duration. Usually that is normal, but may be regularly abnormal. The QRS, usually normal but can regularly abnormal. That's about the ventricular and atrial rhythm. Now P wave, normal and consistent shape, always in front of the QRS. Then PR interval, consistent interval between 0.12 to 0.2 seconds. P is to QRS ratio, that's of 1:1. This is about the ECG criteria of sinus arrhythmia. Now we can see the causes of sinus arrhythmia. Heart diseases, moderate to extreme stress, excessive consumption of stimulants like caffeine, nicotine and alcohol, intake of some medications, These all can cause sinus arrhythmia. Then about the signs and symptoms, usually that is asymptomatic. The sinus arrhythmia does not cause any significant hemodynamic effect. Considering the risk factors, the risk of this disease, not the risk factors, the risk of this disease, reduced cardiac output is the risk. And medical treatment treatment is usually not required until the patient is symptomatic. The patient is symptomatic, find and treat the cause. That about medical treatment. You can observe a picture of inhalation and exhalation and the arrhythmia, how will occur. Now move to sinus arrest or pause. The next one is sinus arrest or otherwise sinus pause. This arrest means nothing is there. Arrest is when the SA node fails to initiate an impulse. It is characterized by absent P wave and cardiac standstill for varying period of time. There is cardiac standstill, that means plain ECG. Again, there is absent period, P wave, for a varying period of time. That means it lasts from 2 seconds to several minutes. That's with the escape beats from the atria, AV junction or ventricular or from the ventricles. Hopefully, this atria, junction or ventricle, they are taking the responsibility of the pacemaker function. That's called sinus arrest, no P wave. Sinus standstill is there. Now we can see the ECG features of sinus arrest. That's QRS rate normally less than 60. Sometimes can be normal QRS rate. Again, QRS rhythm irregular due to dropped beats. QRS complexes usually normal width and constant. There is constant morphology. If escape beats present, these may be of different morphology. There is escape beat, that's from atria or ventricle, any beat is there. So, QRS complex of different morphology depending on their site of origin, from where it originates. But from the atria or junction or from the ventricle, like that. Again, about P waves, already told that's absent. That for a period of time, long period of time, in case of SA block. Otherwise, if it is present means having consistent morphology. On an ECG strip for a long period there is no P wave. Then you can see some. If it is there means there is that is consistent morphology. Then the relationship between P waves and QRS complex. QRST complex absent during period of sinus arrest. That is actually happens. There is nothing a plain line. Absent during sinus arrest. Otherwise, P wave is followed by QRS complex and each QRS complex proceed by P wave. PR interval is normal and constant. If arrest is there, nothing. This is about the features of ECG. Now we can see the causes. Causes during sleep in individuals with healthy heart, they can have sinus this arrest during sleep. Case of myocarditis, another fact, then cardiomyopathy, myocardial infarction, digitalis toxicity, age, elderly persons, a common phenomenon. Then vagal stimulation. Now we can move to signs and symptoms. Sometimes that's of asymptomatic, If symptomatic, you can observe syncope, dizziness, alteration in level of consciousness, bradycardia. These all are the signs and symptoms. Now, what all are the risks of this condition? Sudden chance of cardiac death, that is the risk. Sudden death can occur. Then there is chance of syncope, sudden fall, thromboembolic events. Can be stroke, a thromboembolic event as stroke you can observe in that type of patients. Then CHF, just cardiac failure, heart failure. Then arterial tachyarrhythmias, atrial flutter or fibrillation can occur due to this condition. These all are the possible risks. Now we can see the treatment options. Only treated if patient is symptomatic. Atropine will be required during periods of sinus arrest if adverse signs are present. Atropine is the drug of choice. Then pacemaker. If recurrent and causing syncope, a permanent pacemaker may be required. Then any electrolyte imbalance should be corrected. That's another treatment option. Any electrolyte imbalances that should be corrected properly. Now move to nursing management. Assessment is important. How to assess and monitor the patient, the heart rate, rhythm, blood pressure, intensity, everything how to assess. Next, give oxygen and monitor oxygen saturation. Again, monitor blood pressure and heart rate. Again, if there is no IV fluid, how to start an IV fluid, establish an IV line. Notify the physician. Now, this is about the nursing interventions. Now you can see the ACLS protocol. That include look for the cause of the sinus arrest and treat it. Then proper medication should be given. Then maintain the electrolyte balance. Again, natural deterioration of the cardiac system should be maintained. Then normal cardiac system should be maintained. Then the person may require artificial pacemaker for treatment of symptom if the person is symptomatic. This is about the ACLS protocol. Next, we move to next sinus arrhythmia, that's a sick sinus syndrome. The sick sinus syndrome is a term used to describe a condition that encompasses a variety of cardiac arrhythmias related to abnormal SA node and atrial activity. Both are there, but I included in this category. SA node arrhythmias. Abnormality, both SA node and atrial activity. The common cause of these are syncope, dizzy episodes, palpitation, sick, common in the elderly. Also, it can occur at any age. You can see the definition as such. Sick sinus syndrome describes the dysfunction of the intrinsic pacemaker of the heart, the sinoatrial node. As a result, the heart rhythm becomes abnormal, that is characterized by sinus bradycardia, that's a slow heart rate, tachycardia, fast heart rate, and bradycardia, tachycardia, that means alternating slow and fast heart rhythms. Anyway, it's clear that in this sick sinus syndrome there is decreased heartbeat, increased heartbeat, then alternating, increasing and decreasing type of heartbeat. The mechanism is like that. Normally the sinus node that produces a steady pulse of regular electrical impulses. In sick sinus syndrome, these signals are abnormally paced. A person with a sick sinus syndrome may have heart rhythms that are too fast, too slow, punctuated by long pauses, or an alternating combination of all these rhythms possible. This is about the mechanism. Now we can see the types and causes. Types of sick sinus syndrome and their causes include sinoatrial block. Electrical signals move too slowly through the sinus node, causing an abnormally slow heart rate. Next is sinus arrest, the sinus node activity pauses. Next one is tachycardia bradycardia syndrome. The heart rate alternates between abnormally fast and slow rhythms, often with long pause. That's of asystole between the heartbeats. Now move to the ECG manifestations of sick sinus syndrome. Sick sinus syndrome can produce a variety of ECG manifestations consisting of atrial bradyarrhythmias and atrial tachyarrhythmias and alternating bradyarrhythmias and tachyarrhythmias. Again, supraventricular bradyarrhythmias may include sinus bradycardia, sinus arrest, or without functional junctional escape. Again, you can see the sinoatrial exit block that occurs in patients with the sick sinus syndrome may demonstrate a Mobitz type 1 block and Mobitz type 2 block. The ECG reveal a long pause following cardioversion of arterial tachyarrhythmias. Now we can see the causes of sick sinus syndrome. Actually, that is of unknown, but histologically some degenerations of the conduction tissues between SA node and AV junction. That is considered to be the most possible cause of this arrhythmia. That is relatively uncommon. It may be brought by use of some drugs like digitalis, calcium channel blockers, beta blockers, and antiarrhythmics. Again, the sick sinus syndrome usually occurs in people older than 50, in whom the cause is often non-specific, or scar-like degeneration, or sarcoidosis, cardiomyopathies. These all can be the reason of sick sinus syndrome in old age. In children, a common cause of sick sinus syndrome is heart surgery, especially on the upper chambers. Next, the coronary artery disease, high blood pressure, and aortic and mitral valve disease that may be associated with the sick sinus syndrome. Now we can move to the symptoms of sick sinus syndrome. Most people will with this sick sinus syndrome that initially have few or no symptoms. In some cases, symptoms may come on to later. Slower pulse rate, fatigue, dizziness, lightheadedness, fainting or near fainting, shortness of breath, chest pains, trouble sleeping, confusion, palpitation. These are some signs of sick sinus syndrome. Now move to treatment. The treatment is not necessary if you do not have any symptoms. A permanent implanted pacemaker may be needed if your symptoms are related to bradycardia. Again, a fast heart rate tachycardia may be treated with medications. So, sometimes there is surgery. That's of radio ablation, radio frequency ablation technique is used. So then treatment patients with persistent bradycardia, they will require AV pacing, that's of ventricular pacing or AV sequential pacing. The patient with the tachycardia syndrome, they may require concurrent anti-arrhythmic therapy. When the increasing use of pacemakers, sick sinus syndrome, we can control it. If the person is having any electrolyte imbalances, that should be corrected. This about sick sinus syndrome. Next one is wandering atrial pacemaker. A wandering atrial pacemaker is characterized by the pacemaker wandering from a say node down to the atria or AV junction. Characterized by pacemaker wandering. It is usually related to vagal influences. It can occur healthy young people but may be a manifestation of atrial pathology. Can observe the wandering atrial pacemaker rhythm. The rhythm is benign. This rhythm and multifocal atrial tachycardia are similar except for heart rate. There is significant respiratory sinus arrhythmia with uncovering of latent foci of pacemaker activity. Usually that is associated with the underlying lung disease. In elderly, it may be a manifestation of sick sinus syndrome. In young and the athletic heart, it may represent enhanced vagal tone. Wandering as atrial pacemaker ECG, the QRS rate that usually normal. Rhythm regular. QRS complexes normal width and constant morphology. P waves present morphology and position will vary depending on the site of origin of the impulse. The relationship between P and QRS complexes. Each P wave is followed by a QRS complex. PR interval may vary depending on the site of origin of impulse. This is about the ECG criteria of wandering atrial pacemaker. Then symptoms and signs and symptoms. Usually causes no symptoms and is incidentally discovered. The occasional patient may feel skipped or skip the beat, like that the patient may feel. During the physical exam, variable S1 we can observe. Now about the treatment. No specific treatment, monitor and treat the underlying cause such as other conditions. Now another mode is pacemaker. The indications for pacemaker include if part of sick sinus syndrome, if associated with the documented symptomatic bradycardia, associated with documented symptomatic bradycardia, that time treatment is necessary. The complications of wandering atrial pacemaker may progress to sick sinus syndrome. That's the complication. This condition may progress to sick sinus syndrome. Then prognosis. This condition itself is a benign condition. Next we can see the SA block. Impulses from the node itself is blocked and fails to traverse the junction between the SA node and the surrounding atrial myocardium. That's of SA block. The impulses from the node itself is blocked. This result, the result of this block is that of a dropped beat. Just as with AV junctional block, we can observe a dropped beat. This arrhythmia is recognized electrocardiographically by a pause resulting from absence of normally expected P waves. There's a pause and absence of normally expected P wave. Again, the duration of the pause is multiple of the basic PP interval. The duration of the pause is the multiple of the basic PP interval. The basic PP interval is there, can be 2 times or 3 times or 4 times, like that. The multiple of the normal PP interval is the pausing time. The SA exit block is caused by a conduction disturbance during which an impulse formed within the sinus node fails to depolarize the atria or does so. There is delay in conduction. The SA block, again we can classify that's of first degree, second degree and third degree SA block. Like AV block, SA block also first, second and third is there. The first degree SA block cannot be recognized on the ECG because the SA nodal discharge is not recorded. First degree, there is not recorded at all. That's why we cannot observe on the ECG. During the type 1 second degree SA block, SA exit block, the PP interval progressively shortens prior to the pause and the duration of pause is less than 2 PP cycles. Pausing time is less than 2 PP cycles. The normal PP 2 cycles, consider 2 PP cycles, less than that is the pausing time. The type 2 second degree SA exit block characterizes an interval without P waves that equals approximately to 3 or 4 times the normal PP cycle. Interval is 2, 3 or 4 times that of the normal PP cycle. The third degree exit block can be manifested as a complete absence of P wave and is difficult to diagnose with the certain without sinus node electrograms. We can't identify that in sinus node electrograms. There is absence of P wave. You can see the features on ECG. The QRS rate usually normal, sometimes less than 60. QRS rhythm dropped beats result in an irregular rhythm. QRS complexes normal, width and constant morphology. P waves absent during period of SA block, otherwise if present having a constant morphology. Relationship between P waves and QRS complex. The QRST complex absent during a period of QRS complex and each QRS complex is preceded by a P wave if there is P wave and PR interval normal and constant. These all are the features of ECG. Now we can think about the causes of SA block. That include excessive vagal stimulation, acute myocarditis, cardiomyopathy, idiopathic fibrosis of SA node, that is the important cause, fibrosis of the SA node. Then drugs like beta blockers, digitalis quinidine, procainamide. Then another cause is myocardial ischemia or infarction. Another one is sick sinus syndrome. These all are some causes of SA block. Sometimes this SA block can occur in a well-trained athletes also. This type of SA block, well-trained escape rhythm. Some possibility book says is like that. It has got a little clinical importance, the SA block, except that it may be a manifestation of intoxication by digoxin. Only one clinical this importance is there. Intoxication by digoxin or other arithmetic drugs. There is significant, that SA block is significant. Or again, if there is electrolyte imbalance also, SA block that is having some significance. This is all about different types of sinus arrhythmias. Sinus arrhythmias we discussed. Which are sinus arrhythmias? Sinus bradycardia, sinus tachycardia, sinus arrhythmia, sinus arrest, sixth sinus syndrome, wandering atrial pacemaker, and SA block. The concerned ECG strips also are attached to this class. Some pictures attached. You can observe the strip and find out the peculiarities of P wave, QRS complex, PR interval, about rate, about rhythm, and try to understand ECG strip. Okay, thank you.